All right, in this lecture, we are going to be diving into two incredibly important systems in pediatrics, the integumentary system, or the skin, and our sensory organs. Now, Engage covers quite a bit more than what I'm going to call out here, and so just remember that you should be familiar with all the information, but I'm going to be personally focusing on what I see come up most often clinically and on exams. So let's kick things off with some background. Remember, the skin is the body's largest organ. It's doing some serious heavy lifting for our PEDS patients. This is their first line of defense. It's this protective barrier against the outside world. It also plays a crucial role in preventing insensible fluid loss, body temperature regulation, and perceptions of pain, heat, and cold. And so just like an onion, the skin has layers. Ogres have layers. It's a really bad Shrek reference. There's an interactive image in the Engage module if you need some review here, but basically you've got the epidermis on top, which is your outermost layer, and then we move into the dermis, which is where you're going to find a lot of the action, right? Your nerves, your blood vessels, your hair follicles, and then underneath it all we have the hypodermis, which is the fatty layer that provides insulation and cushioning, and then beyond that you're looking at the muscle layer. So just understanding these layers will help understand how different skin conditions manifest. We also want to think about the differences in skin and lymphatic system in children because kids are at greater risk for things like inflammation and irritation due to having a thinner epidermal skin layer. They're going to be more likely to have primary and secondary complications from skin integrity alterations, like from cuts and cellulitis and burns. They could lead to maybe secondary infections. And then they're more likely to have injury from irritants like the sun or fragrances or tape and monitors. So this section is going to consider skin disorders that are caused by physical contact with the skin. Okay, we're going to talk about dermatitis, which is an inflammation of the skin resulting in redness and itching. We have different types of dermatitis. We're going to be talking about things like contact dermatitis, poison ivy, diaper dermatitis, seborrheic and atopic dermatitis. And then we'll also talk about medication reaction, talking about one of the most common medication hypersensitivity reactions, which is xanthamitis or maculopapular drug eruption. Okay, this is like a measles-like medication-induced rash. So our different types of dermatitis include a contact and an allergic variation. So this can affect different aspects of the skin. So we're going to look at contact dermatitis as a whole. Now this is super common, especially in kids. It's inflammation that occurs when the skin encounters an irritant. So you might have had this before yourself. Irritants can include substances like perfumes, things like jewelry or plants. Generally, contact dermatitis will actually worsen with increased exposure time and concentration of whatever the causative substance is. Our risk factors for contact dermatitis will involve exposure to the irritant or chemical, right? So all children are at risk in some way. So think about how much they're exploring their environment or touching things or mouthing things. Presentation of this contact dermatitis involves redness, itching, swelling, vesicles, and oozing. It's usually diagnosed via physical exam and a history, but the gold standard for diagnosis would be an allergy patch test. The most effective prevention in that case would be avoidance of the triggers once we know what they are, and so treatment for dermatitis is mostly supportive. We could do things like oatmeal baths or cold wet compresses to reduce itching, plus over-the-counter antihistamines, some topical corticosteroids, or even systemic steroids if the reaction is severe. This should be pretty familiar as there are overlaps with the infectious skin conditions that were discussed in the previous module. So contact dermatitis is not just a rash. It can have a pretty big impact on a child's overall health. If you think about the psychosocial aspects, a child with an itchy visible rash might feel self-conscious or irritable. Developmentally, it can interfere with their sleep or their play or even their learning. So people also in general just love to talk about rashes. If you haven't had a peer ask you about a suspicious rash yet, just wait. Now imagine it's a parent, right? Rash assessments come up a lot. So we educate about the treatment and the importance of keeping fingernails trimmed to prevent secondary infections, and we will also educate on avoiding triggers. Rashes are super common for school nurses. I feel like I worked in the schools. That was the thing, besides giving medications, that I saw the most of. And it's hard because rashes can look alike, and it can be really hard to determine what's causing them. It's also important to note that children may describe pruritus and itching in different ways. Some may describe it as scratchy or bad or like needles. Others might say it's painful. This is often the most challenging part for parents because it can seem impossible to provide comfort for their child. So supporting the family and offering non-pharmacological managements like cold compresses or distraction or mittens so that they don't scratch, loose clothing, or whatever else might help in that situation is really useful. Now, poison ivy we're going to talk about quickly because poison ivy and poison oak are pretty common in this region, and kids are traipsing through bushes almost daily. You can see from this photo the characteristic linear pattern from brushing against the plant as it goes against the skin. This is considered a hypersensitivity reaction involving the epidermal and dermal layers of the skin, but it also involves the lymphatic system a little bit. You may have learned the rhyme, leaves of three, let them be, but if it's hairy, it's a berry. If you didn't, now you have a new survival skill. You can see how both the poison oak and ivy in this picture have three leaves coming off of that central branch. So they're pretty characteristic when you're looking for them out in the wild. Diagnosis is based on history and presentation for this. One neat bit of trivia is that you don't need to touch the plant to develop a reaction. It can actually be transferred from clothing or animal fur or fingernails or tools that have brushed against it. The chemical, it's called urushiol, I can never pronounce it, can be aerosolized by burning. Okay, so another interesting bit of data for this is that children around 8 and older are sensitized and more likely to develop allergic contact dermatitis to poison ivy, but then as they get older, that potential for a reaction actually decreases. So the rash initially will present as papules, move on to vesicles, and then bulla about 1 to 4 days after contact and can last up to 3 weeks without treatment, but it ultimately is self-limiting. Antihistamines, again, can be used for itching, and it's just important to let parents know that diphenhydramine or Benadryl can cause a paradoxical effect in children. So instead of sedation, it can make them really hyper. And so caregivers need to know, hey, your kid might be really, really sleepy, but alternately they might be bouncing off the walls. Much of the impact of this overlaps with contact dermatitis. A primary prevention measure is to wear long sleeve clothing in wooded areas. Obviously, outdoor play is crucial for development and outweighs the risk of exposure. So we're not keeping kids inside to avoid poison ivy, but parents should know where their children are playing to prevent any unknown contact with these plants. The other dermatitis we're going to discuss is diaper dermatitis. This is a very big peds thing because we have a lot of diapers in peds and therefore a lot of diaper rash. So while this does seem to be a fairly mild and common condition in infants and toddlers, it can impact overall health and has some greater implications into caregiver education and also socioeconomic status and resources. So our diagnosis is made from clinical presentation. Again, diaper use, my hair is falling out, I'm just going to have to take it down. Diaper use, like frequency of changes or their hygiene practices. Irritation will usually result from prolonged contact with urine and stool or from infections from candida or staph. Infants have immature skin, as I mentioned, and it's thin. So this sensitivity combined with that constant exposure to moisture definitely increases risk of skin breakdown. So every infant usually has some form of diaper rash at some point, but there's a whole spectrum of severity here. We'll use barrier creams for diapers and diaper changes at the first sign of any moisture, but this can be challenging for some families because of financial limitations. Diaper need is higher in families with lower education and higher use of formulas and disposable diapers. So with the high cost of disposable diapers, some parents might delay changing diapers or use cheaper, thinner diapers, or even attempt early toilet training to decrease diaper need. Alternately, over-cleaning with caustic soaps or wipes can also damage the skin and cause breakdown. So our biggest concern with diaper rash is infection due to damage to the skin barrier and then its proximity to bacteria from the stool and the urine. So what does this mean for us? We need to educate parents on changing diapers frequently, right? We need to clean the perineal area with a soap-free cleanser or perfume-free wipes. And then skin barriers like Vaseline or lanolin or zinc oxide can be used in a thin layer with each diaper change. And if a rash does occur and is getting worse, we can utilize topical steroids for short term or nystatin if it's fungal. Sometimes in the hospital, we'll even have them go diaper free. If we've had really bad skin breakdown, we'll put a baby prone on their stomach with their butt in the air. And sometimes we've done a diaper on, but with oxygen, the thicker tubing that you would see connected to a high flow or a blow by inside the diaper so that it's just drying out their bottom, or we will just have them go diaper free if they're a little bit older and they're not constantly incontinent to help them heal because that air helps dry things out. But there's usually no long-term effects. This is typically self-limiting. It could have an impact on parental mental health and decreased quality of life for the child and the family due to the socioeconomic limitations, allowing the purchase of enough diapers. But usually this is just something every parent goes through, and as long as it doesn't get bad, we can treat that over the counter at home. Okay, medication reactions. This most common medication hypersensitivity reaction, like I said, is called exanthamatous or maculopapular drug eruption. They call it MPR. It's a measles-like rash, usually caused by allopurinol or various antibiotics. Some anticonvulsants and antiretroviral drugs are usually the most common. So this is a cell-mediated reaction that involves the epidermis, the dermis, and the lymphatic system, okay, similar to poison ivy. Some risk factors include underlying disorders of the liver or kidneys where they're not metabolizing correctly, infection with cytomegalovirus or Epstein-Barr, and then children that have immunodeficiencies. But the incidence rate for these are honestly at about 2% of the population, and most will present with this maculopapular rash. Now, drug reactions happen in stages, okay? So the first exposure will result in a rash within about 7 to 10 days, and now we have sensitized that child. And so that then means that any subsequent exposure will result in a rash earlier, within 1 to 3 days. So I have a penicillin rash. The first time I had penicillin, I had a rash like a week into it, and then the doctors were like, we're not going to do this anymore because penicillin is a very common culprit. But had I had it again, I very likely would have had a much more severe reaction much sooner in the treatment. This also happens with other allergies like bee stings or food exposures, right? That first exposure is usually not too bad. It is the second one that's going to cause a problem. This rash will usually appear on the torso and proximal areas, but it can spread to the feet and hands if it's severe enough. Treatment is supportive. Usually we stop the medication, right? That's the best way to do it. We'll use cetirizine or Zyrtec. That's actually our preferred antihistamine over Benadryl or diphenhydramine. We have talked about those other occurrences of skin infection, but what happens when the injury happens and bacteria gets in? We get cellulitis. Okay, so you can see how red and swollen and angry this looks. It's not comfortable. It can occur after bug bites or stings or injuries or an inflammatory condition, like anything that can access through the skin barrier. Our most causative agent here is group A strep. So this looks like inflammation and erythema in those dermal and subcutaneous layers of the skin. There is a clear demarcation between affected and unaffected skin. So you'll often see in the hospital, if someone comes in with cellulitis, we're going to mark the edges with a marker so that we can see if that redness is spreading or if it is improving with antibiotic use. It's usually really painful and tender. If it does get severe enough, you will have vesicles as well as some systemic symptoms like fever or fatigue or malaise. Usually the diagnosis has to include 2 of the following, okay? Warmth, redness, swelling, and tenderness, all right? Blood or tissue cultures could be required to determine the causative agent so that we could use the right antibiotics. And there's also a risk of osteomyelitis if the wound is deep enough or situated over a bone. As I said, we're going to use antibiotics for this. We'll start with oral, and if they fail oral antibiotics, they might come into the hospital for IV antibiotics, or if it's determined to be MRSA, they're going to need some more aggressive treatment. So in the hospital, we'll usually see kids whose cellulitis failed that oral trial, or they've developed an abscess that needs stronger treatment. But usually once they're on IV antibiotics, we'll see improvement within about 24 to 48 hours. All right, finally, we're going to talk about burns. I cover this not because it's something we see clinically, because severe burns are going to be on a burn unit, but because ATI and NCLEX are obsessed with burns. So when assessing burns, we do use specific tools like the Lund-Browder chart, which is tailored for pediatric patients because their body proportions are different from adults. So you might remember the rule of 9s when we talk about adult burns, but you can't apply it to a baby whose head is proportionally much larger than an adult's head to their body, for example. So we have our own chart, just like we do in peds for most everything. The treatment for the burn is going to depend on severity and cause. You'd approach treating an electric burn differently than a chemical burn. And then severity is going to be determined by the depth of the tissue involvement. So either superficial, partial thickness, or full thickness. We do have risk for decreased perfusion at the area where the coagulation is occurring. And so those damaged tissues will release vasoactive mediators, and fluid will then move into the interstitial space around the burn, which is why sometimes you'll see burns seem wet, right? And that's because the capillaries are more permeable, okay? And so we have that water loss, which is why we get very concerned about shock in those cases. For treatments for minor burns, we're going to just cool the area, we're going to clean, and we're going to prevent infection. So we're going to use cool water and a mild soap, not cold water, not ice, okay? And we want to do pain management just with over-the-counter medications. If it's a moderate to severe burn, we're going to need provider treatment there, and so they should be transferred to a hospital. We're going to be focusing on ABCs at that point, fluid resuscitation, because of that interstitial shift and that fluid loss, pain management, and then wound care with sterile dressing change. And then pain management is going to be more intense, right? We're going to be talking like morphine, fentanyl, narcotics at that point. Thermal injury can make people very anxious. They can have psychosocial distress, especially if they're hospitalized for a long time and there's frequent dressing changes and wound care. It can be really stressful and painful. Toddlers might regress, right? Older children might have body image concerns. So you can think about how this all goes back to development. Ultimately, we want to prevent burns. We always are teaching parents to turn the pot handles to the back, make sure that there's no open fires, ensure that we aren't microwaving formula so that the formula is not getting overheated, and we're checking the temperature of food, setting water heater temperatures to no higher than 120 degrees. So there's all these things that we do to try to prevent burns. Ultimately, accidents happen, and sometimes we do see this. This is the Lund-Browder chart that I mentioned. So as you can see, we've got different parts of the body that have different percentages, and that is how we determine the total percentage of the body that has been affected by the burn. Skin is done. I'm probably going to skip this or split this into two. So after this, we'll move on to sensory nervous.